Good evening, Dr. Varun sir.
Good
So
evening. Good evening.
we'll start the session now.
Yeah, yeah, sure. Should I start? Hello.
Yes, sir, you should. Well, this is the Cardiology Class 3 taken by Dr. Varun Pushkarna, who is the Senior Consultant in Internal Medicine, Fortis Escortis in Hospital Amritsar. Thank you.
Yeah, thank you, Sana. Welcome all the students. So we are set to do cardiomyopathy and heart failure today. I would say that these are the very important question-bearing topics in MRCP exam and in cardiology. Whenever we are done with the ischemic heart disease and hypertension and other, the next major topic is this only. So basically, cardiomyopathy is of many types, but for the sake of examination, we will be covering only few of them, and those are the major ones. Now, we will start with the most common and most commonly asked cardiomyopathy in the exams, that is DCMP. So DCMP is basically when all of the chambers are dilated. So if I would say this is the normal heart, so if I say this is the normal heart, then in case of a dilated heart, we will see thinned out LA, thinned out RA, and a thinned out ventricles. So we will see something like this. So this is an LV, and when LV should have been like this, some good thickness muscle. Here it is thinned out. So it's basically a dilated heart. By definition, all the four chambers, one, two, three, four, all of them should be in a dilated state. Not because there is a lot of volume in it, but because the muscle has given away and it has dilated. So there is dilatation of all four chambers, thinning of the muscle, and muscle means systolic function. Muscle means strength. Muscle means tone of the heart. So that is lost, leading to systolic dysfunction. One of the major reasons for heart failure with reduced ejection fraction. Etiology: idiopathic, familial, viral myocarditis, alcohol, toxins like chemotherapy, doxorubicin, peripartum cardiomyopathy. Endless is the list. And when list is endless, all you can say is idiopathic. So DCMP, usually you will never find a cause. Where you can find a cause, they are like alcoholic cardiomyopathy, peripartum cardiomyopathy, then they are named according. Sometimes even viral myocarditis can lead to a dilated heart, but usually it is the left heart which is dilated immediately after a viral disease. Sometimes one can have a all chamber dilatation. Then there is something known as Takotsubo cardiomyopathy, in which typically the heart is flask shaped left ventricle. So infundibular portion has in fact increased tone. So there is a hypertonia here and there is hypotonia here. So the heart seems like a flask. So that is Takotsubo, usually because of extreme stress, either psychological or physical. So septic cardiomyopathy can also present like Takotsubo. Clinical features will be failure of the heart to be a good pump. So the patient will have features of heart failure. Which heart failure? Systolic heart failure. What will it show? It will show pulmonary edema. Pulmonary edema will manifest as fatigue. Pulmonary edema will manifest as breathlessness. It will manifest as cough. It will manifest as pink frothy sputum. It will manifest as lethargy. Cardiac output will be decreased, unable to meet the requirements of the body. So patient will be fatigued and lethargic all the time. Then because this heart is dilated, and so this heart is dilated, not only the left ventricle, also the atria. And atria we know have got the bundle of Kent and all the SA node to AV nodal connections. So when they are stretched, there are chances of arrhythmias, there are chances of conduction abnormalities. Then because this is a ventricle which is thinned out and it is not contracting very well, so there is some amount of blood which is there inside the cavity which will undergo stasis, and in medicine stasis will lead to clot formation. So thrombus might be formed. Thromboembolism is a problem. Sudden cardiac death because of ventricular arrhythmias can lead to sudden cardiac death. What are the investigations? How can I draw this photo? Because with time we have mastered a technique known as echocardiography. So when we do an echocardiogram, we can see the dilated chambers of the heart, thinned out muscle of the heart, that is when we call it as a dilated heart. And along with, we can calculate the ejection fraction and call it heart failure with reduced ejection fraction. Now we will discuss the heart failure in the next coming slides. For right now, it is the DCMP is one of the leading causes of heart failure with reduced ejection fraction. In ECG, because the left ventricle is stretched so much, the His bundle will also be stretched. Purkinje fibers will also be stretched. So the signal that is coming from SA node to AV node and then to His bundle and Purkinje fibers to the left side of the heart, they will reach late. And because this conduction reaches late on the left side of the heart, it leads to left bundle branch block pattern in the ECG. There can be non-specific changes in the ECG, STT changes because of the dilated. How will you manage? You cannot bring this heart back to its original location. This is dilated. But what you can do is you can reduce the preload. So diuretics, very important drug, nitrates. By decreasing the preload, these drugs, they lead to increase in the cardiac output. And by Frank Starling's principle, as the left ventricle keeps on getting filled with more and more blood, it tends to increase its contraction until a tip-off point. So when it dilates beyond that point, there are chances of stroke volume falling down drastically. So this is where it helps by decreasing the preload. Then decreasing the afterload. This is a poor heart. Imagine somebody as a rickshaw puller. So the rickshaw puller in the rickshaw puller is the dilated heart, and the passengers in the rickshaw, they are the preload, and the wind blowing in front of the rickshaw puller is the afterload. So the rickshaw puller is finding it extremely difficult to pull the rickshaw because of its muscle mass is gone now. He's thinned out. Now what you can do, you cannot make the muscle mass better all over again. So either you have to unload the passengers or you have to decrease the wind blowing from the front. So by unloading the passengers, I mean to say preload is decreased. By unloading the wind fall coming from front, I mean that I will bring down the blood pressure. So if this is the rickshaw puller, and my drawing is not very good, but then this is the rickshaw, and this is the wind flowing from front, and this is the passengers. So what you can do is you can unload these passengers, the rickshaw will move faster. You can decrease the wind blowing, the rickshaw will again move faster. Or you can put a support here that we will discuss. That is different. So heart failure management will include ACE inhibitors. We can tell the rickshaw puller to to cycle the pedals slowly. Slowly it does, more it moves without getting fatigued. So beta blockers, very important to control the heart rate. Diuretics to unload the patient. Aldosterone antagonists to unload the patient, also to strengthen the muscles a bit. If the risk of sudden cardiac death is high, we know that the risk of sudden cardiac death is because of the VTVF. So putting a patient on ICD is important. And rare and severe cases, heart transplant is the key. Then comes another type of cardiomyopathy, hypertrophic cardiomyopathy, HCM. Now, HCM can be of two types. One is obstructive, the other is non-obstructive. So not all hypertrophic cardiomyopathies are obstructive in nature. It is a congenital disorder. It is autosomal dominant, causing myocardial hypertrophy, commonly of the interventricular septum. So if this is the left ventricle and this is the muscle of the left ventricle, so this is the muscle of the septum. Now you can see the ventricular cavity could have been this big, but now it is just this big. So because of this is a muscle, it can go into crampy situation. It can just go into a spasm, and it can actually shut down the infundibulum. So when it shuts down, the aorta goes into a sudden closure and there is no blood flowing out of aorta. And this condition is known as sudden cardiac death. So leading to diastolic dysfunction and LVOT obstruction. So left ventricular outflow obstruction is there. Etiologies, genetic. So you can find mutations in the sarcomeric proteins, including beta-myosin heavy chain and troponins. Clinical features are exertional or asymptomatic syncope. Now, what is syncope? Syncope is due to no blood flowing through aorta when the heart goes into something situation like this. I'll show you. So this is the IVS, this is the LV free wall, and aorta had to take blood. So what has happened is it has gone into a spasm. So this, because this is a muscle at the end of the day, it can go into spasm if the muscle tone is high. So there is no blood flowing out of the aorta, out of the left ventricle. So this leads to a sudden cardiac death. Okay, and syncope, of course. Dyspnea, angina. Why angina? Because coronaries, they originate from the aorta, and all the coronaries, they originate from aorta just beyond the aortic valves. So that means if the blood is not flowing from aorta into the aorta, then these coronaries also remain unfilled. So angina pectoris will happen. And sudden cardiac death is also a real possibility. Echocardiography will show asymmetrical septal hypertrophy. This is asymmetrical septal hypertrophy. You see, I have drawn it in an asymmetrical manner. Systolic anterior motion of the mitral valve. So what happens is mitral valve is here. So let us say if the anterior leaflet moves in every systole, it can shut down the left ventricular outflow tract also. So same in the mitral valve. As far as the ECG is concerned, it will show LVH pattern, deep T wave inversions. So we will have something like this in the ECGs. So this is in V2 to V6, one can find such a pattern. So this is not a myocardial infarction T wave inversion. This is a T wave inversion due to hypertrophy of the muscle. So how do you treat this patient? You don't want them to go into spasm. So best drugs are beta blockers. Don't let this heart go into a spasm and lead to sudden cardiac death. So either beta blockers or calcium channel blockers for this purpose. Nitrates should be avoided. Why? Because nitrates will decrease the preload and the patient will have tachycardia. So diuretics will also do the same thing preload. So this interventricular septum is kept away from the left ventricular free wall because of the volume inside the cavity. So if I'm going to decrease this volume, then there are chances that they can this left LV cavity can go into a closure because of contraction. Septal, and how do you treat it? You put ICD for to prevent sudden cardiac death and do a septal myomectomy. So what will I do? I will just put in a alcohol ablation here. So what will it do is, so this is the aorta. Now aorta is also getting good blood. This is the mitral valve. This is also doing good. So I have released and I have increased the cavity of the left ventricle. So this is the HOCM. Then the restrictive cardiomyopathy. Are you understanding everything? The dilated and the hypertrophic cardiomyopathy, students? Yes?
Yes, sir.
Good. So now coming to restrictive cardiomyopathy. So in restrictive cardiomyopathy, the basically what has happened is this muscle, the left ventricle, instead of being elastic, it has become firm like a metal, like steel. So what will happen is it can still contract, but it cannot dilate. So if my heart had to be somewhere here, it is just placed here. It will contract and come back to this shape. That is all. So this is called restrictive cardiomyopathy. So what is the kind of failure here? Systolic is fine. So it is a diastolic dysfunction. It is a filling defect. Diastolic dysfunction will be there. So there is impaired diastolic filling due to stiffness of the myocardium. It is just like somebody has a injury in his elbow and they cannot open up their arms. Although they can, but because of the stiffness of the elbow joint, they cannot open. That is similar situation here. So etiologies are when the muscle is infiltrated by some substances like amyloid, sarcoid, and sometimes we don't find anything. Sometimes it's eosinophilic fibrotic myocarditis, or scleroderma even can lead to this. Okay. So the clinical features are right-sided heart failure, because the left ventricle is not taking blood from the pulmonary circulation. So we have lungs here, we have this heart here, and this heart has to take blood from the right ventricle, right? So if the right ventricle is trying to give blood to the lungs and the lungs are giving it to LV, but LV is not taking it, the preload is getting collected here, then it will lead to pulmonary hypertension, and this pulmonary hypertension will lead to right ventricular failure. So this will lead to cor pulmonale, that is secondary to the pulmonary condition. So because usually what I've seen in restricted patients, the lung is also restrictive pattern. So right-sided heart failure, peripheral edema can happen. So whatever remains in gets collected in the abdomen. So liver will increase in size, congestive hepatomegaly will be there, pitting edema at the peripheries, pedal edema will be there. More prominent are left-sided. And once you put in a stethoscope, you may not find much in the chest. There will not be pulmonary edema. So the chest will be clear. And because of the heart beating at a lower preload, there can be syncope and some arrhythmias. Echocardiography will show normal sized ventricles with biatrial enlargement. So atria will be enlarged. Why? Because of the continuously increasing preload. Cardiac MRI may show in amyloidosis, amyloid deposits. Classic pattern with gadolinium is there. Definitive diagnosis can be established with the help of endomyocardial biopsy, which is not available so easily. So you have to treat the underlying cause, chemotherapy for amyloidosis, steroids, all of them will help. Diuretics are important to decrease the pedal edema and excessive preload reduction. But the problem is that the cardiac output here is based on preload only. So you should avoid excessive preload reduction. Diuretics are just for symptomatic relief. The liver will go fine, ascites will decrease, pedal edema will decrease, but the cardiac output will decrease even further. So patient's fatigue will be increased. Last but not the least is arrhythmogenic right ventricular cardiomyopathy, ARVC. Very important, will come in Mrcp exam every year. So basically what happens is, this is an isolated cardiomyopathy of the right ventricle. What happens is a fibrofatty replacement of the muscular tissue in the right ventricle. Now this fibrofatty tissue leads to arrhythmias. Usually it is ventricular arrhythmia, VT. So it is literally an explosive kind of a VT storm that happens. So etiology is genetic, where desmosomal protein mutations are there. And clinical features are palpitation, syncope, sudden cardiac death, usually during exercise, and RV failure in late stages. ECG will show T wave inversions in V1 to V3 and epsilon waves. Echo MRI will show RV dilatation, wall motion abnormalities just in the RV. So patients should avoid strenuous exercise. Patients should always be on beta blockers to prevent arrhythmias, and sometimes they will require flecainide, procainamide, mexiletine, so on and so forth, amiodarone. So many drugs they need to be on. Sometimes even digoxin we start to these patients to prevent arrhythmias. And you can put a ICD for prevention of the sudden cardiac death. All right. So I would now like to have contributions from you all. So kindly you can unmute your phones so that we can have a discussion. So there is a 25-year-old male who is an athlete and collapses suddenly during a football game. He has a family history of sudden death. ECG shows deep T wave inversions in lateral leads. So what is the most likely diagnosis?
Hypertrophic
cardiomyopathy.
Very good. So this is hypertrophic cardiomyopathy. It as such is a most common cause of sudden cardiac death in young athletes, and especially with a family history of sudden cardiac death. ECG findings of deep T wave inversions in the lateral leads V2 to V6, they are highly suggestive of this thing. A 60-year-old woman presents with dyspnea and peripheral edema. Echo reveals normal ventricular size with bilateral enlargement, biatrial enlargement, and poor diastolic filling. So what do we have here? Echocardiography findings. What is the diagnosis?
restrictive
cardiomyopathy.
So what are the features that are hinting towards restrictive cardiomyopathy?
Right-sided heart failure.
Right-sided heart failure symptoms.
Okay. Features of right-sided heart failure. Fine. And is there
Normal
anything?
Biatrial.
Yes.
Biatrial
Normal
enlargement.
ventricular size, but marked biatrial enlargement on echocardiography. Okay. So that is also very important to remember the echo findings. Many times echocardiography reports show biatrial enlargement and we just tend to pass. But if you read it very carefully, they will be mentioned diastolic dysfunction grade 2, grade 3. that will be mentioned. So PA pressures will be elevated in these patients. So they will be coming. So you should always insist on asking, why did you get your echocardiography done? Was it chest pain or was it just breathlessness on exertion? So people will tell you that, okay, we got it done because the chest physician asked, because he had treated me for bronchial asthma for last 10 years. And now he feels there's something wrong with my heart. And this is what I got this echo done. And then you can say, fine, you have a pulmonary condition which is also affecting your heart. So maybe you have a sarcoidosis. So that is the time when you should start investigating for it. Although, as I told you, definitive diagnosis can only be established with the endomyocardial biopsy, but usually it's not available. So you can do these days you can do a CMR. What is CMR? Cardiac MRI. So it is very important to do cardiac MRI. Although in amyloidosis of the heart, it has a very characteristic picture, but certainly it can still show very, very importantly dysfunctional myocardium in cases of all the restrictive type cardiomyopathies. Okay.